when I'm doing this by myself, I really appreciate when Peter's here and we can both do separate things. But it just takes about 30 seconds to get one thing going here. All right. All right, so next up, we are very fortunate to have Umar Sharif Khawaja giving us a multidisciplinary presentation. He is originally from Pakistan, and he's a first-year endocrinology fellow here. Prior to coming here, he did his internal medicine residency at Rutgers and also did a hospitalist period of time at Jersey Shore University Medical Center. We're very lucky to have you here, Umar, and looking forward to your talk today.
Thank you everyone for the invite. And we work very closely with the neurosurgical team on a lot of patients, and I think this is a great opportunity to give a face to the endocrine service. And I'd also like to thank my program director, Dr. Levine, for giving me this opportunity as well. I'll take over the screen sharing if that's okay.
Go for it.
And is everyone able to hear me?
Yes.
All right. Are you able to see my screen?
Yeah, looks good.
Okay, so the topic that I chose for discussion was prompted by a case that I saw recently, and it really intrigued me and wanted me to delve more into it, and it's pituitary hypophysitis. So let's just dive deep into this case, and it's a case-based discussion. I think that would be more helpful in understanding the disease process. So it's a 21-year-old student with a past medical history of panhypopituitarism who presented to Mount Sinai Endocrine Associates and established care with Dr. Alice Levine on October 2021. He was diagnosed initially with panhypopituitarism back in Oregon and moved to New York to attend University of Columbia. So basically his initial symptoms were polyuria and polydipsia, and he had an MRI finding at that time in August 2020 in Oregon, which was significant for thickening of his pituitary stalk. His initial workup back in June 2020 showed an ACTH, which was less than 1.5 low. Cortisol was 3.7 low. IGF-1 was 128 low. His estradiol was 45.7, a bit high. FSH was less than 0.3 low. LH serum was less than 0.3 low. His prolactin was elevated at 104. VT 4.66 low. TSH 0.048 low. Total testosterone 71, which is low. He had a high serum sodium of 152. His urine osm was low, and his urine specific gravity was low, and he had a high serum osmolarity. So he had panhypopituitarism due to hypophysitis and was started on full hormone replacement therapy with hydrocortisone, levothyroxine, testosterone injections, and DDAVP tablets. So for this talk, I decided to divide it into the definition of hypophysitis, the causes, and is there a role of steroids and biopsy? So let's talk about definition first. What is hypophysitis? Hypophysitis is characterized by the inflammation of the pituitary gland, the infundibulum, caused by an autoimmune, infiltrative, infectious, neoplastic, or sometimes an unknown pathogenic process. The diagnosis is based on the initial clinical presentation and in conjunction with the MRI findings and lab findings. So this is basically a picture. This is not a picture of our patient, but it's more of a classic picture of hypophysitis. It's a T1 pituitary MRI. You have the coronal view and the sagittal view, which is basically showing an enlarged heterogeneous enhancement of the pituitary gland with mild thickening of the pituitary stalk and some deviation of the optic chiasm. How do these patients present? So half of the patients of hypophysitis would present with headaches. while 10 to 30% would present with visual disturbances, and these are related to the mass effect. Patients may present with symptoms of hormonal deficiencies. So the presence of both anterior pituitary dysfunction and DI is kind of like a hint that there's something of an inflammatory process going on. There might be an infiltrative process. It could be a craniopharyngioma, a germinoma, or it could be metastasis, and is highly unlikely that this is a pituitary adenoma. In lymphocytic hypophysitis, and this is a very important point, and immunotherapy-induced hypophysitis, so the two types of hypophysitis can present with an initial deficiency of your corticotrophs, followed by gonadotrophs and thyriotrophs. And corticotrophs are life-sustaining hormones. So this is very important to recognize, as treatment can be life-saving. This pattern is distinct from pituitary adenomas, in which you lose your gonadotrophs and your IGF-1, then your thyroid hormone, and the last to go is cortisol. So nature is kind. So causes of hypophysitis. These can be divided into primary and secondary. Primary causes arising from the pituitary gland could be lymphocytic hypophysitis. They could be an inflammatory or an infiltrative process that's going on from within the pituitary gland. Secondary causes would be anything outside the pituitary gland: drugs, neoplastic process, systemic disease, autoimmune disorders, infection. So I'm sorry, this is kind of a busy slide, but I think it's a very good one to kind of go back to our patient and kind of rule out what our patient could have and could not have. Immunotherapy-induced hypophysitis. So this is a rising cause of hypophysitis as more and more immunotherapy is being used for cancer treatments. It's giving endocrinologists a lot of business. So it's usually caused by any drug pretty much that ends in MAB. That's one way that I usually remember it by. It's more common in men, but older men with a diagnosis of like a malignancy, which our patient did not have. It also presents more with anterior pituitary defects and corticotroph loss. And our patient had posterior pituitary defect on presentation, DI. So this doesn't go with the picture that our patient presented with. The next is IgG4 related disease. Again, common in men, kind of goes with our patient, could have it, but at an older age, it's usually seen in the 5th and 7th decade of life. Our patient's a young man. Also, it usually has other symptoms and signs that these patients usually present with. It causes massive fibrosis all over the body, involving your thyroid gland, famously like renal thyroiditis or pancreatitis. There's diffuse lymphadenopathy. And a lot of these patients initially, 40% present with diffuse symptoms of allergies. Our patient did not present with any of those. And with that said, our patient was also tested for IgG4 back when he was initially diagnosed in Oregon and at Mount Sinai, and it was negative. But the important point to make is these patients do have anterior pituitary defects, and they do initially present with DI as an initial presentation. And that kind of did go with our patient. The next type of hypophysitis is the main chunk of hypophysitis, and that's lymphocytic hypophysitis. And it can be divided into primary and secondary hypophysitis. And let's take a deeper look into this. So primary hypophysitis, also called lymphocytic hypophysitis, the most common cause, 70% of the cases are due to this. It's more common in females. Our patient was a male, kind of goes against it. Age of distribution is bimodal. Younger people can have it. So that kind of goes with our patient. It's often seen in women in the 3rd trimester of pregnancy. These patients usually have other autoimmune disorders going on as well, like type 1 diabetes, celiac disease, which our patient did not have. These patients usually present with anterior gland hormonal deficiencies. DI is uncommon. So our patient presented with DI, goes against it. Lymphocytic hypophysitis, secondary dysgerminomas. highest in young males. That goes with our patient. Often associated with pan-hypopit and DI. That goes with our patient too. Tumor markers are often negative. You check an AFP and a beta ACG in these patients, but tumor markers can be negative. Our patient's tumor markers were checked back in Oregon and they were negative. Imaging may guide diagnosis, but may need a biopsy to confirm the diagnosis, especially in cases in which tumor markers are negative. These patients are not glucocorticoid responsive. They usually require radiation, surgery, or chemotherapy, depending on the underlying etiology. And now back to our patient. So our patient is a 21-year-old man who was diagnosed in Oregon with acute onset panhypopituitarism and DI, and had MRI findings that were consistent with hypophysitis, and is on full hormone replacement therapy and DDAVP. His initial and repeat workup was negative for IgG4 related disease. Given the DI and male young age, this germinoma would be very high on the differential. Markers were negative for beta HCG and AFP, like I said before, but they can be negative. The patient was discussed at the multidisciplinary Pituitary conference in October 2021, and the decision was made at that time to start him on high-dose steroids to try to reduce the mass effect. Now, this gives the perfect moment. Is there a role for steroids, and is there a role for biopsy? So the mainstay of treatment for primary hypophysitis is steroids. But according to a German cohort study, like 46% of the patients with a milder hypophysitis can just be observed, and you just replace hormone replacement as needed. Glucocorticoids can be used to reduce mass effect, but usually with these patients, you do not see a recovery of their hormonal axis. The doses for steroid treatment, they vary widely. It can be 20 milligrams of prednisone per day, and in some literature, they recommend using pulse dose therapy with up to 1 gram of methylprednisone per day. There is no clear duration of how long to treat as well. And you basically observe the response to therapy, as we decided to do in our case. There's no randomized controlled clinical trial assessing the efficacy and use of steroids. And the reason for this is that hypophysitis itself is not very common. Do we need a pituitary biopsy? A biopsy can be used to establish hypophysitis histopathologic type, and it should be considered when initial investigations or when pathology results are needed for treatment. Do we want to give long-term glucocorticoids? Would immunosuppression be a choice? Or are we going to have to do chemotherapy? There are no established criteria for pituitary biopsy in adults, and if considered, risks and benefits should be discussed with a multidisciplinary team. And this is the approach that we used with our pituitary conference for our patient. Now back to our case. Our patient was put on prednisone 30 milligrams daily for 6 weeks. He had a repeat MRI done in December 2021 and was compared to his previous MRI in October 2021, pre-prednisone, and it was largely unchanged. The decision was made to pursue a pituitary biopsy, and the results were, it showed a germinoma with syncytial trophoblasts. But the plot thickens. Post-op pituitary biopsy was seen, and the patient was recommended to follow up with Dr. Fakianos, and he, on exam, discovered a testicular tumor, and this prompted further investigation. He said that he recommended getting a PET scan done, and the PET scan for our patient did not show any evidence of metastatic disease. So his thought process at that time was that this could be either a skip lesion or the patient has two different tumors, two different primary tumors. Also, going back on chart review, neither the patient ever complained of a testicular mass, and neither did Dr. Levine on the initial examination back in October 2021 feel any mass. His beta HCG had been normal, but in March 2022, it was slightly elevated and it was checked pre his orchiectomy. Could there be a growth of testicular tumor related to high-dose prednisone? Dr. Sfakiano said it's possible. He status post the radical orchiectomy in March 2022, and his pathology was consistent with seminoma. And he's currently planned for RT to the pituitary lesion. He's status post treatment for the seminoma as it was resected. To summarize everything, hypophysitis is a rare entity, but it's becoming increasingly common, especially with the use of immunotherapy. And we're starting to see a lot more cases in the hospital during inpatient consults and even in our clinic. The diagnosis is based on imaging and hormonal testing. Lymphocytic hypophysitis is more common in females, and patients can be observed and they may recover on their own. The important thing about this is that you usually lose your cortisol axis first. So this can be life-threatening. And it's the same case with immunotherapy-induced hypophysitis. You lose your cortisol axis first. Panhypopituitarism and DI would usually indicate a secondary cause. Think of like a germinoma, a granuloma. And I did not delve into other secondary causes of hypophysitis because that would be a very long discussion and suited for another day. And it did not go in line with the case-based discussion that we're doing. Steroids can be given to reduce mass effect, but no clinical trials exist. And these patients, despite steroid therapy, usually do not recover their hormonal axis. Biopsy is needed in unclear cases. And these are my references.
Thank you very much, Umar. That was a lovely introduction and overview. We have Dr. Levine here, and I would like to ask you for comments. But before we do that, I would like to just show a little bit of what we found at surgery, because I saw that you were referencing several times the concept of a pituitary biopsy. But of course, this is not really a pituitary biopsy. So some of you who've seen this will recognize this was a 21-year-old with central DI, panhypopit, who in October had this lesion of the pituitary stalk of 2020. And then a year later, you see the expansion along the stalk, not involving the pituitary gland at all, extending up and behind the optic chiasm and into the third ventricle. For many reasons, as you saw, we decided to do the biopsy after the markers were negative. And this is the initial approach here. And you can see a suprasellar approach. This is the pituitary gland below. This is a fellow, by the way, who's holding the endoscope. And so you can see there's too much movement. One of the joys of the teaching institution is the learning curve of the people you work with. But what you're seeing here, and I'll show it to you again, is the optic chiasm. So pituitary gland, optic chiasm, anterior cerebral artery. This is the pituitary stalk. And to the left and behind it is the mass growing up along the dorsum of the stalk and up into the third ventricle. And so the way to do the biopsy here was to make a linear incision into the tumor and to get a bunch out of it. Here you're seeing the mammillary bodies behind, below the third, with this growing up into the third. So that was the biopsy itself. I see that we have Dr. Levine here. Can we get your comments, Alice?
Sure, that was great. It was lovely seeing those photos of the actual biopsy there. What strikes me is when we look at, because I'm a non-surgeon, I never actually get to see these things. So all I see is the MRI, and on the MRI, it looks like it's part of the stalk. Are you able to tell on the MRI that it's like outside of the stalk?
We saw it was eccentric, and that's why I did a left-sided approach. And there was one view on a coronal view where you seem to see some differentiation, but even the coronal view is pure coronal, and as you saw, and as you know, the stalk is rotated posteriorly. So as you go superiorly, it goes superiorly. So you would need a cut that's reconstituted halfway between axial and coronal to really show that, and it just didn't seem warranted. But we knew it was on the left side, so that's why we approached it that way.
Yeah, and also, so I was going to say that that when we were reviewing this, because Umar was, decided to do this topic, and he really did a great job, and I was really kind of surprised about the steroid stuff, that it is not well studied at all, and we picked some dose of 30 milligrams and just said, all right, we'll do it for 6 weeks, and it's really like a Turkish bazaar there with the steroids, and the actual outcomes. It looks like the only entity where steroids are actually beneficial would be in that IgG4 related disease. There, if you recognize it and you give steroids, you can prevent fibrosis. But that's really the only argument that can be made for steroids, other than to reduce a mass effect. So that was a little bit eye-opening to me.
And obviously the other curiosity here is the development of a 4-centimeter testicular mass de novo in someone who had a normal exam 6 months before. And by the way, he mentioned that it turned out to be a seminoma. These are identical histopathologies. Seminoma of the testicle is the germinoma of the stalk and in the pineal region. And we do have an upcoming pediatric neuroradiology development discussion that Tom Nadich is preparing to explain how these things occur as synchronous lesions.
Oh, that'd be great. That'd be great for us to be in on. So yeah, very enlightening case. I thought very enlightening. And I always like to do it case-based, because in retrospect, it seemed like the evidence was all there that this was a germinoma. And perhaps we could have foregone the 6 weeks of prednisone, although it's easy to say in retrospect.
Well, there were wiser people in the department than I who called it the germinoma before we biopsied it. One of them was Ben Rappaport, who said, "Oh, what are you talking about? That's obviously a germinoma." Young guy, and so on. Why are you even biopsying? He didn't say it to me, but I heard he said it to someone else. So, all good. Great. Any comments or questions? If not, I think we can kind of wrap it up.
I have one comment, which is, for me, it always is interesting that the stalk in the infundibulum is such a complex structure metabolically, and it has, venous and otherwise releasing factors, but it's obviously small and it's hard to image. Is there ever indication, and I don't know if there's an answer, Alice, to do like metabolic studies when you see hypophysitis, like, some of the uptake studies or other things to try to look for localization? Is that even relevant or
Well, I'm not sure I understand the question. What kind of study? Like
uptake, like like the type of studies you would do for a cancer workup or a metabolic workup for,
right.
or something like that. Or
I think, not that I know of, and not in most of the review articles. Again, this is a fairly rare entity, except we see a lot of pituitary patients, so it's not that rare for us. And now, Umar had referred to this, but we see a lot of it because of immunotherapy. But in there, what's going on, so there would be no indication. That's become a fairly common referral for us. But so not that I know of, not for the I
Yeah,
don't
I
know
mean,
of any studies on
it
that.
may be hard. I understand that it may be hard to really see such a small anatomic location, but I just feel like it probably has some role in this, and at least in terms of differential.
What is the downside? I know there was no downside here, but biopsying up in the in that region, what do you warn the patients about that could happen?
A lot of bad stuff. A lot of
Yeah.
bad stuff. Blindness, hemorrhage, leakage, hypothalamic damage. I would consider this a high-risk biopsy.
Okay, so I guess that's why we did the prednisone. It was sort of.
Yeah.
Yeah.
I mean, but like you said, with the expertise we have both in pediatric neurosurgery, if this guy had been a month younger, maybe someone else would have been involved. But and the fact that we are doing so many complex transnasal endoscopic cases over the past few years has made this much safer. But I wouldn't talk about it too lightly. We saw another case on Monday that Dr. Larson presented of a growing mass in the infundibulum that I'm recommending. It's actually in the third ventricle, you may recall, that I am recommending excisional biopsy on. So we're getting pretty comfortable there, but many people might not feel comfortable with this.
Terrific.
Great. Leslie, do you have any comments?
Yeah, I was, for an outpatient skull-based pituitary PA, I will say that I think I roll my eyes a little bit with anything in the infundibulum, or if anything comes back hypophysitis, because we really don't know what we're doing often and not really sure how to manage the patient. But I was just thinking about scanning. So we have all these special protocols that we use for Seller protocol, orbital protocol, specifically the orbital protocol with obliques and fat saturations. I wonder if we could, go back and look at the patients that had these, because we had a run of these for a while, and see if there's any special sequencing that we can do that maybe gives us more information. Because the thing that we always tell patients is that we want to avoid the biopsy.
Leslie, as always, a good idea, practical, and we don't have it. As you know, when we want to look at the optic nerve, we've got to do an oblique sagittal, right? Because the optic nerves go from medial to lateral as they traverse the orbital apex. As we discussed, the pituitary stalk goes from anterior to posterior as it goes from caudal to rostral, and there are no coronal. The normal coronal view is just rostral caudal. So I think you just came up with a very good idea. As well, we have the volume. And since Umar is here, Umar, would be a great project for you if you want to, and maybe even if you don't want to review all of our pituitary stalk lesions. Maybe vis-a-vis the question of the predictive value of modern MRI. That would be a specific hypothesis or question in predicting the biopsy results.
I think that would be a very interesting thing to look into. Definitely.
And then you can work with Leslie and the others to develop a protocol for imaging.
Dr. Post actually gave us a very good lecture recently at a noon conference, just talking about this topic, about like different imaging findings that you would expect in a Rathke cyst versus a germinoma versus just hypophysitis due to immunotherapy. And an adenoma. It was very helpful actually for us now. Like we're starting to look at MRIs and starting to look into these patients before the reads come back. So I think that's a great thing to do.
So I thank you, Josh and Leslie, as the fellowship director for giving Umar a very good second year project. That's great.
Okay. Thanks, everyone.